Hi, welcome to the surgical lecture series. In this lecture, I will cover the overview of the surgical conditions of the thyroid. In this, we will discuss the surgical anatomy of the thyroid gland and the various abnormalities of the thyroid gland. So, first of all, we will concentrate on surgical anatomy of the thyroid gland. So why anatomy of the thyroid gland is so important in surgery? It's simply because thyroid has various congenital remnants which are important to understand for the management of that remnants. Not only that, the thyroid is related to several important structures which can be damaged and cause complications after thyroidectomy. Because of this, the surgical exams incorporate several questions in surgical anatomy of the thyroid gland. Under the surgical anatomy, there are few important objectives we need to understand. First, we need to know what is the importance of the development of the thyroid gland. Next is what is the importance of the blood supply or the blood circulation of the thyroid gland. Then the lymphatic drainage. How the understanding of the lymphatic drainage influence the management of certain thyroid cancers. And last, what are the nerves that is related to the thyroid gland and what is the importance of that. Development of the thyroid gland. The thyroid gland begins to develop during the third week of gestation as an enterodermal thickening in the floor between the first and second pharyngeal pouches. So the formation of the thyroid gland is from the floor in between the first and second pharyngeal pouches. Later this thickening becomes the thyroglossal duct. The floor later develops into the foramen cecum of the tongue, which is situated in between the anterior 2/3 and the posterior 1/3 of the tongue. The parathyroid glands rises from the third and fourth pharyngeal pouches, and there is an odd thing happen here. That is, superior parathyroids rises from the fourth pharyngeal pouches and the inferior parathyroids from the third pharyngeal pouches. This is because the parathyroid glands rise from the third pouches, descends with the thymus into the neck, and later named as inferior parathyroid gland. So that is how, even though the inferior parathyroid gland rises from the third, because of the descents, comes lower down, and then it is named as inferior parathyroid gland. So what is the clinical implication of this? The clinical implication is the superior parathyroid glands are in a constant position because it is not mobilized. But because of the descents of inferior parathyroid gland, the position of the inferior parathyroid glands are variable and sometimes situated in the neck. The thyroglossal duct migrates caudally, and by the 7th week of gestation, the thyroid gland reaches its final position. The descent of the thyroid may be arrested at any point in between the base of the tongue and the trachea, and this leads to ectopic thyroid tissues anywhere along the descent. So lingual thyroid is the most common form of incomplete descent. Other variations and implications of descent are it can be a thyroglossal cyst or a fistula, or the pyramidal lobe and the retrosternal or a intrathoracic goitre. Is it pyramidal lobe is present in every individual? The answer is no. The pyramidal lobe occurs in about 33% or 1/3 of the individual. This is how the lingual thyroid appears. It is situated in between the anterior 2/3 and the posterior 1/3 of the tongue. So this is the place earlier we have discussed the flow in between the first and second pharyngeal pouches, later develop into a foramen cecum. During the migration of the thyroglossal duct, it passes anterior to or posterior to or through the developing body of the hyoid cartilage that later develop into a hyoid bone. The importance of this is considered during the surgical removal of the thyroglossal cyst called cyst trunk operation. So because of the close relationship to the body of the hyoid bone, during the cyst trunk operation, the body of the hyoid bone is also removed with the thyroglossal cyst and the tract. If we consider the anatomical position of the thyroid gland, it extends from middle of the thyroid cartilage to the sixth tracheal ring. This extension is important for the exposure of the gland during thyroidectomy. The isthmus is situated in between the second and fourth tracheal rings, but in about 10% of individuals, the isthmus is absent. So, thyroid gland has its own true capsule, but outside to this, the gland is enclosed with pretracheal fascia, and it is attached to trachea and laryngopharynx through the fascia. This is the reason why thyroid gland moves with swallowing. Not only the thyroid, there are some other structures also moved with swallowing, such as thyroglossal cyst, subhyoid bursa, and any lymph nodes which attach to pretracheal fascia. The right lobe is larger than the left, and the normal thyroid is about 20 to 25 gram in weight, and it is slightly bigger in female. But the normal thyroid is not palpable. That indicates if a gland is palpable, then it is abnormal. When we come to the blood circulation of the thyroid gland is supplied mainly by the superior thyroid artery and inferior thyroid artery. It has several branches of supply through tracheal and esophageal branches. In about 3 to 10% of individuals, there is a thyroidea ima artery that is arising from the aorta or brachiocephalic trunk, and it supplies to the isthmus. The superior thyroid artery is the first branch of the external carotid artery. Because of this, the pressure of the blood flow is very high. This can lead to torrential bleeding during and after the thyroidectomy if this vessel is damaged or the slippage of ligature occurs. Other important thing about the superior thyroid artery is the external branch of the superior laryngeal nerve is in close proximity to the superior thyroid artery. So avoid the damage to the nerve, superior thyroid artery is ligated close to the thyroid gland. So inferior thyroid artery has the close relationship with the recurrent laryngeal nerve. So recurrent laryngeal nerve run anterior or posterior or in between branches of the inferior thyroid artery. Because of this close proximity of the nerve to the branches near the gland, the inferior thyroid artery was ligated away from the gland in old era. But the main blood supply to the superior and inferior parathyroid glands come from the inferior thyroid arteries. So the ligation of the inferior thyroid artery away from the gland will lead to ischemia or necrosis of the parathyroid glands and permanent hypoparathyroidism. Because of this reason, nowadays the inferior thyroid artery is ligated near the thyroid gland as individual branches, and we don't ligate the inferior thyroid artery away from the gland. So nowadays it is ligated near the gland. Next, about the venous drainage. The thyroid gland is drained by superior, middle and inferior thyroid veins. The most important vein is middle thyroid vein. Why it is important in surgical practice? It is wide and fragile vein, and damage to this vein lead to torrential bleeding, especially when it is avulsed from the internal jugular vein. And the other important thing about middle thyroid vein is this is the first vessel to ligate during thyroidectomy for the mobilization of the thyroid gland medially. And you might note that there is no middle thyroid artery that accompanies the middle thyroid vein. So we have middle thyroid vein without middle thyroid artery. So the lymphatic drainage of the thyroid. The principal lymphatic drainage of the thyroid gland is level 6. That is it is called the central nodes. And central lymph node dissection should be carried out during surgery for medullary carcinoma of the thyroid. So that is the surgical importance of central lymph nodes. Then the lymphatics will be drained to the deep cervical chain, such as the levels of 2nd, 3rd, 4th and 5th lymph nodes. There will be a drainage to the mediastinal lymph node, that is level 7. The cervical lymph node block dissection to be carried out in papillary carcinoma of the thyroid if there is any evidence of a cervical lymph node metastasis. So in this, the most important surgical implication is in medullary carcinoma of the thyroid, the central lymph node dissection will be carried out even whether it is enlarged or not. But in papillary carcinoma of the thyroid, the cervical block dissection will be carried out when there is an evidence of lymph node metastasis. If you consider the nerves related to the thyroid gland, there are two important nerves that is related to thyroid gland. These nerves are external branch of superior laryngeal nerve and the recurrent laryngeal nerves. The external branch of the superior laryngeal nerve is related to the superior pedicle, that is the superior thyroid artery. So damage to this nerve leads to loss of high pitched sound, and this will affect the voice of the people who are using the high pitched sound, for example the singers and teachers. To avoid the damage to the external branch of the superior laryngeal nerve, the superior thyroid artery is ligated close to the gland, and that will avoid the external branch of the superior laryngeal nerve. So recurrent laryngeal nerves are related to the branches of the inferior thyroid artery. There's a difference in between the right and left recurrent laryngeal nerve. So left recurrent laryngeal nerve recurs lower down, that is caudally, around the arch of the aorta, so it has more deep and vertical course in the tracheoesophageal groove. But in right recurrent laryngeal nerve recurs higher up, that is in cranial position around the right subclavian artery. So this nerve has a lot of variation and oblique course when it joins the tracheoesophageal groove. Because of this difference, the chance of damage to the right recurrent laryngeal nerve is higher compared to the left recurrent laryngeal nerve. So, damage to the unilateral recurrent laryngeal nerve will lead to hoarseness of voice, and damage to bilateral recurrent laryngeal nerve will lead to stridor and respiratory compromise. Few points about the histology of the thyroid gland. So thyroid gland consists of follicles, and in between the follicles there are parafollicular cells. Follicles consist of follicular cells, and in the center there are colloid. Follicles secrete the thyroxine, and the thyroxine is stored within the colloid. And in this, The thyroid gland is the only endocrine gland that stores the hormone outside the cells. So in between the follicles there are parafollicular, or we call C cells. These cells secrete calcitonin. So the medullary carcinoma of the thyroid arises from the parafollicular cells, and the papillary and follicular carcinomas are arising from the follicular cells. So to recap the surgical anatomy of the thyroid gland, we discussed about the importance and the variability of the development of the thyroid gland. Then how the blood supply and drainage interferes with surgery. And we have discussed the importance of lymphatic drainage and the most important nerves that is related to the thyroid gland. Next section we will concentrate on abnormalities of the thyroid gland. There are three kinds of thyroid abnormalities. So all the thyroid problem or thyroid abnormalities we can classify under these three headings. The first, it's epidemiological abnormalities of the thyroid gland, and the second one is the functional abnormalities of the thyroid gland, and the third one is the morphological abnormalities of the thyroid gland. So epidemiological abnormalities depends on occurrence of abnormal thyroid gland. They can be endemic, sporadic, and familial. Functional abnormalities depends on the secretion and blood level of thyroid hormones. It can be divided into hypothyroidism and hyperthyroidism. Morphological abnormalities can be due to generalized swelling, that is we call goitre, and the other abnormalities can be discrete swelling, or we call it a nodule. It's epidemiological abnormalities of the thyroid gland. As we discussed now, the epidemiological abnormalities are endemic goitre, sporadic goitre, and familial thyroid diseases. When more than 10% of the local population develop goitre because of the geographical reason, it is called endemic goitre. The endemic goitres are mainly due to the iodine deficiency, and because of this, it can occur from the childhood. What are the areas in Sri Lanka that are related to endemic goitre? So if you can see the Sri Lankan map, we can divide the zones of Sri Lanka into two, the dry zone and the wet zone. Endemic goitres in Sri Lanka are related to the wet zone. So the districts comes under the wet zones are examples for developing the endemic goitre. The second type of epidemiological abnormalities is sporadic goitre. So sporadic goitres are mainly due to the defective hormone synthesis, and this usually occurs during the puberty. And the third epidemiological abnormality is familial thyroid diseases. So familial thyroid diseases are mainly the autoimmune diseases such as Graves' disease and familial thyroid dysharmoniogenesis disease. The well-known familial thyroid cancer is medullary thyroid cancer, but there are familial non-medullary thyroid cancer also exists, that is arises from the follicular cells. So under the thyroid abnormalities, we have discussed about the epidemiological abnormalities of the thyroid gland. In our next lecture series, we will discuss about functional abnormalities of the thyroid gland.